Good afternoon, everybody, and thank you for joining us for our webinar today on integrating care transitions, strategies through enterprise process, people, and technology. Our goals today, our learning objectives, are really four broad areas. To look at the issues of readmissions reduction and understand how to put in place a program that integrates people, process, and technology. To do that so that you have consistent, effective strategies across different service lines in your hospital or your healthcare setting, to look at how to deploy those processes and technologies that work both within your organization, but also expand to other facilities and the broader care team that your patients have. And lastly, how you should be tracking that, and what might be some things that you want on a dashboard or reports so that you can watch the outcomes and the benefit and impact of the programs that you put in place. By way of background, Digital Collaboration Solutions is a consulting and services company that helps hospitals and other healthcare organizations with care coordination and patient and provider engagement. We focus at working in a results-oriented basis to help our customers get measurable results through improved outcomes and improved financial results in the important areas of care coordination. We're not a software company. We use the best-of-breed technology when that's appropriate, or we might often use technology people already have. But our focus, as we'll talk about, is really looking and saying, how do you do that in an integrated fashion? Because technology may or may not be the right answer, but certainly it has to align with the people and the processes. Let's start by looking at the issues. What are the root causes of ineffective transitions of care? The Joint Commission, and we all know them, did an in-depth study of transitions of care. And what they looked at and said was that there were three main areas of breakdown that are the root cause. The first of those is what they call accountability breakdowns, meaning that it's not clear who owns and who's accountable for patient outcomes. The patient moves through transitions and through the continuum of care. And one example of that was a survey that was done that showed that 9% of physicians have admitted to what's called turfing patients, just moving them to someone else in the care continuum, which is obviously not great for the patient. The second area the Joint Commission identified were communications breakdowns. And a good example of that were discharge summaries, which reach the PCPs by the follow-up visit only 12 to a third of the time, meaning that often a patient is coming out of an acute or other inpatient type setting, and when they get to their PCP for a visit, the PCP doesn't have the information they need. The last area that the Joint Commission identified was patient education breakdown. And it's critical to recognize that the patient is a part of the process, and they have to be integrated into the care. A study showed that when you looked at patients 65 years or over, 54% did not accurately recall instructions about their follow-up appointment. And that exemplifies how breakdowns can happen in engaging with patients and how those lead towards issues of ineffective transitions of care. And as we go through our webinar today, we'll look at how you address these causal factors. As I said, the way we look at that is by saying we need what we call a balanced performance. You have to integrate the people, the processes, and the technology in a way that achieves the goals and measurable outcomes. There's so many times people will try and use technology and find that it fails because the people that are using it don't have the knowledge and understanding, or the processes are not well aligned to use the technology. And it's a complicated dynamic between technology and processes because you'd like the technology to reflect your process. At the same time, anytime you put in technology, you're going to be making changes to processes. So you have to work those together, keeping in mind that healthcare is a people business. And what's critical is that the people know and understand what you're trying to do and have the information that they need and the knowledge and understanding. So let's start with that inner circle right here, goals and metrics. And the first question you want to ask is which measures are critical to your healthcare organization? And we look at those through the AAA model of quality of care, financial impact, and patient experience. And we lay out here some of the critical measures that organizations are following and watching and often being judged on or that have financial impact. So of course, important to us today, because we're thinking about readmissions, is your measures of unplanned 30-day readmission. And what are those numbers? How much are you getting readmission? How do you compare to your peer group and so forth? And of course, the CMS 30-day readmissions penalty has an immediate financial impact if you end up having more unplanned readmissions than your peer group has. Of course, it's a complicated formula, but it can have very substantial, even millions of dollars of financial impact on a hospital. And then lastly, things like 30-day readmissions can have a big impact on patient experience. Patients don't want to come back to the hospital. And ultimately, that shows up when you ask your patients how they're doing, how they're feeling about care through things like HCAHPS scores. And that, once again, circles back around and is a part of some of the financial impacts through things like the hospital value-based purchasing CMS program. So number one, what measures are you following? What measures are you not achieving your goals? What measures do you want to change? And if you don't understand those things, how are you going to sort through, understand which measures matter, which measures don't? Since we're all submitting measures, we are watching them. The challenge now is to pick the ones where we want to make change and then effectively implement change. That leads us then to that first section, goals and metrics. And now we move on to the next part, which is to start to think through and look at processes. And I really look at that. There was just very recently a article published in Health Affairs magazine. It was published last month, May of 2015, by Walker and Carrion. They're both out of Geisinger. And they talked about what they called process-focused care versus task-focused care. And they said, as we say here, that process-focused care is patient-centric, and most importantly, that in thinking that way, you coordinate the work of the broad care team members across all of the different care organizations and what they call venues of care. And doing good quality process analysis and redesign requires methodical thinking. To start on the left, here is an example out of something from the Pittsburgh Regional Health Initiative that showed a process element for typical chronic disease management. And on the right, how they started to redesign that when they said, how are we going to do a better job? How are we going to focus at reducing readmission? What changes do we need to make? Business process reengineering is a well-worked subject and an area that people have lots of understanding as we look and say, how do I move from that today process model to the new process model, keeping in mind the approach that says I want to be focused across the whole care continuum. When we do that, we start to see that addressing processes can address the root causes that we talked about of ineffective transitions of care, those areas that the Joint Commission identified. First, in the area of accountability breakdowns, by carefully and methodically looking at our processes, we're able to define clear-cut processes with clear participants who have responsibility. We also can importantly do things like assess risk and put contingency planning in place and do a better job of managing our resource requirements. One example of that is an organization that we worked with that said, look, they're getting overwhelmed in their emergency room. And if they could understand where their emergency room visits were coming from, which of those were areas that they could start doing interventions earlier and reduce emergency room visits, that had multiple benefits. Benefits in terms of care quality. You don't want people in the emergency room. Benefits financially. Emergency room visits are expensive. And in this organization's case, they had a fair amount that were uninsured, so they effectively hold the bag. And lastly, patient satisfaction increased. Similarly, careful thought to processes can improve communications breakdowns by clearly laying out what you're communicating and to whom you're communicating it, and defining the handoffs and the acknowledgments. Yes, I have the patient. Lastly, you can do a better job with patient education by integrating patient education into the processes, specifying the education content, and carefully thinking through what education occurs when and by whom. You will end up with more knowledgeable and more engaged patients. And as we've said, that has an impact on care. So our second area, thinking through processes, allows us to impact the root causes of ineffective transitions of care. The third area that we talked about is people. And once again, people are critical to delivering healthcare. A study by the Commonwealth Fund on reducing hospital readmissions looked across top-performing hospitals and came away with several key points that are here. First, you have to integrate the hospital and outpatient care, and you have to build formal or informal relationships between hospitals and all of their various care providers, clinics, nursing homes, home health care agencies. It's complicated and it's a lot of work because we move our patients through a very complicated continuum of care. And you have to have close cooperation and coordination as you do that, so you can understand patients' needs and patients' preferences. For example, we talk about palliative and hospice care. But as a result, you can help reduce unwarranted and unwanted readmission. So people are critical, and the studies show that people are critical. So that readmissions reduction team, therefore, is broad. It includes the patient. It includes the patient's family. It includes all of the various clinicians, both in the acute setting and in the post-acute setting. It includes home care providers or pharmacies, and this list could go on and on. Key questions that you need to ask are, do you have the right people and organizations involved in an integrated patient care plan? And your readmissions initiatives has to involve them, but also has to be broad-based within those groups. Don't just say, I'm going to talk to the top end of the food chain, to the leadership organization of a home care provider. Go and engage with the actual home care nurses and home care staff and understand what's going to work for them or not, because when you get in there, they ultimately have the power. They're the ones at the patient, working with the patient, and you want to make sure that what you're doing fits them and they're knowledgeable and educated. In that process, you'll have a very well-planned approach and support of all the users and all the people who are involved in readmissions reduction. And lastly, think about where's the biggest bang. You can't do everything at once, so start by picking places that have the most impact. And we'll talk about that in a minute as we look in more depth at how you might select those areas. That says you've got to understand and analyze your care community. What is the care community? What are the demographics of your patients? What are the location of the facilities that they're doing into the patient? Are your patients local or coming from far away? If you're a magnet hospital for a large geography, a lot of your patients might be staying in your area, even in hotels. They might be using local post-acute or tertiary providers. If you're less of a magnet and you're dealing with a regional area, then you can really understand who those facilities are, what the relationship is with your hospital, and things like ownership. Are they owned by a national chain that's distant and not engaged and focused at the bottom line? Are they owned by people in your community who really understand the values and the needs of your community? You want to think about this in the context of your service lines, because different organizations will be in the care community for different service lines. And we'll touch on that again in a few minutes. And you want to think about it through the lens of the patient. Who is responsible for the patient? Who owns the outcomes and care quality? Who owns patient experience? Who owns financials? Because you want to understand who's going to be guiding the patient through the care continuum, or if there's no one who fits that need, then you really need to identify someone. Patient-centered medical home models, if you're working through that, certainly strive to accomplish that. And as you move towards things like shared risk and ECOs, that starts defining a clear ownership. And don't forget that informal but critical care community, family and friends. One hospital we worked with in an inner city area looked and said a key element to getting patients back for follow-up appointments post-discharge was understanding who the family and friends were that were going to bring an elderly-oriented patient demographic to the hospital, to the follow-up appointment. Because it wasn't the patient getting themselves there, it was the niece, it was the wife, it was the brother who was going to be doing that. And lastly, in our changing business models for healthcare, we're moving from fee-for-service to other models. And as you do that, understanding how the different participants fit financially is going to have an enormous impact. One study said that when it's all said and done, aligning financially has more impact than almost anything you can do to get the care continuum and the care community aligned to achieve your goals of admissions reduction or other care goals. When it's said and done, there's a challenge, and our friend Dilbert brings that out when he says you're going to follow the project plan. We'll have the usual arc. Phase one, everyone will have unwarranted optimism and support by delusions of confidence. But in phase two, the obstructionists will slither out of their lairs and try to smother our dreams. And I hate to say it, but we see this in real life. Everybody says I'm on board, but then are they really on board, or do they start asking questions? And when the inevitable bumps happen in your programs, are people going to stick with it and help to work them out? Or are they going to declare it not my problem and I wasn't the cause of why we're having problems? You need to work this issue and align people and see if they are aligned to achieve results. Well, the next area of our balanced performance approach is technology. And there are so many technologies that you can use in care coordination and care transitions today. And you need to inventory what you have, and you need to understand which new technologies are coming out so that you can use them optimally. And first is recognize the many types of technologies. Electronic health records and related hospital information systems are certainly a core clinical system that we're increasingly trying to use to have information about the patient in a consistent fashion and in a combined fashion so that people are all in the care continuum are all seeing all the information about the patient. Out with that, we're seeing an increased number of what we call care coordination systems. They often sit, if you like, on top of the clinical EHRs or HISs and allow information to be shared across those different systems. Now, a lot of organizations will say, well, we're going to use our hospital information system, and everybody will use that. But ask some hard questions there. Is a visiting nurse, is a home health aide going to be using your major hospital information system? My guess is that that company couldn't afford to do that. People are going to say, well, let them go into the portal. But the portal isn't going to be the place that they're taking day-to-day clinical notes and information about the patient. One way or another, it's being recorded, even if it's on paper or if it's on that organization's home-developed or other system, and you need to get it into your hospital information system. And you need to bring it and integrate the data. Not easy, but if you want to have visibility to what's going on with your patient, you're going to need that sort of integration. That leads us to communication technology and health information exchanges, which are elements of the technology that you use to bring information together and to track patients as they move through the continuum. And lastly, we're all seeing that as a mobile issue. Everybody wants to use these technologies on mobile devices, from iPhones to iPods to who knows what new devices are coming out. And that list, the list of technologies goes on and on. So in order to effectively use care coordination technology, recognize that technology is a valuable tool that can really work to improve transitions of care and lower readmission. But also recognize that the technology must improve the processes and support the processes, and must support the people involved. I don't know how many organizations you really talk to the users of a large hospital information system, and the first words out of their mouth are to say, I hate this system that we're putting in place. Why? Maybe it's because the system is one that isn't working for them, isn't a good system, or maybe it's because there's been inadequate training, inadequate hand-holding, that sort of thing. Another thing is to recognize there are a lot of hot new technologies out there. We all would love to be able to do all of these things on our iWatch, but that might not be the best answer, and you don't want to use those new technologies just for their own sake. You want to say, how are these technologies going to help us? How are we going to fit them in to our approaches and our processes, and how will they ultimately address those three areas of causes of poor transitions of care? At the same time, don't recognize that new technologies like mobile can have an incredibly important impact. Care coordination technologies are still immature. There are many, many, many tools and systems out there, and there will keep being those. So what you want to do is take a hard look at how to fit them in, how to make them effective, and how to use them in that balanced and integrated approach that we described. Well, the next question, and the next one of our learning objectives, was to look and say, okay, how do we do this effectively across the different service lines of our healthcare organization? And the thing we suggest to you is recognize that different services have different post-acute requirements and different post-acute organizations that are involved. For example, orthopedics is often a very structured service. Treatment plans tend to be similar, and they have very specific post-acute providers like physical therapy, for example, that are being used that might not be used elsewhere in your post-acute world. In contrast, cardiology is highly varied. The diagnoses behind cardiology, heart failure, MI, things like that can be very different, and the causes can be very different. So you get pretty varied care plans based on different patient needs, which means thinking through what the different care plans are and understanding them and working with the different post-acute facilities is important. When you look at other diagnoses that are subject to the CMS readmission penalty, like COPD and pneumonia, a key thing to keep in mind is those are often comorbidities. So in truth, the patient didn't come in with that diagnosis, they came in with a different diagnosis. And so reducing readmissions due to those diagnoses requires understanding the primary diagnosis, the service that brought them in, and then intertwining the care plans. So transitions of care must take into account different service lines and their differences and have different processes put in place. To understand service line needs, we have suggested approaches here. Start with the diagnoses that are subject to CMS penalties. Understand the impact by service line and diagnoses, rate of admissions, the volume. If you've got a high rate of admissions but only have 4 patients a year, maybe you don't care, versus not as quite a high rate of admissions, but this is hundreds and hundreds of patients. So look at the volume and the rate interconnected. Look at the related population characteristics, comorbidities, and severity, so that you can understand which areas and which diagnoses and which service lines have the greatest need. Identify the service line care team. You've got to understand the treatment plans, the various post-acute providers that are involved, and the need for things like home care, family involvement, or don't forget other resources required, like home oxygen. And are you aligned with the various provider organizations? A good example there is lots of people are starting to use med-to-bed or med-to-home programs. They address a key thing, which is getting medications in the hands of your patients either right as they're discharged or right after they get home. But if you don't follow up and make sure they're getting refills, if you aren't understanding whether the patients are using the medications they have, you've only gone part of the way. Another issue is looking at readiness for change. Different services and different organizations might have different readiness for change. It might be things they've seen in current or past transition programs. It might be whether they're employed by your organization or affiliated, financial interrelationships. It might be relationships you have with post-acute institutions. One organization we talked to said the biggest challenge they had was that the local SNFs, skilled nursing facilities, had been bought by a national chain. The national chain had effectively gotten rid of good people to improve their profitability, and if they had a tough patient, turfed them right back to the hospital. The hospital got the readmissions, the most expensive and difficult patients, and the SNF didn't care. The CFO said it so strongly. He said, talking to this skilled nursing facility company is like talking to a wall. If that's what's going on, you're going to have to think through how do you address what's fundamentally a business and relationship issue. And again, when you've started thinking through service line needs, it allows you to develop a priority list where you focus at those initial lowest hanging fruit. And you can be methodical and quantifiable as you think through some of these things. So now we've looked and said, look, we've got to have goals and metrics to align our people, our processes, and our technology. And we want to implement a quality readmissions reduction program and improve transitions of care by aligning those areas and doing them effectively. And we've seen how processes can impact the 3 causes of breakdowns of transitions of care, and we've seen how we can use people, process, and technology to do that. The last thing you want to do is say, look, it's critical that I track how I'm doing. If I'm going to be metric and driven and results driven, you need to have the capabilities to know where I am. So you need to ask first, what information do I require? And that brings us back to where we began. What is the care quality, financial, and patient experience metrics that are important for your organization and that you're watching? And those are the ones should be front and center of your reporting or your dashboard. And you want to be able to break those down in different ways around different readmissions reduction programs, around different diagnoses, around different service lines, that sort of thing. So you need the flexibility to look at it the way you want to look at it. An example is an organization that is effectively a very, very large ACO, about 125,000 lives. They divided their clinicians, some 2,000 plus clinicians, into groupings and put a person in charge of each group of physicians, and they try to get physicians that work together. And they provided those groups with dashboard information that reflected that group and said, look, you want to focus at each individual clinician, each individual doctor, but also focus at this group that you're working with so that you can jointly improve care, because frequently you're moving people back and forth within that grouping. That took a lot of work to both identify the measures, identify the groups, get the technology in place for these doctors to be able to follow the information for their group, and then also be able to drill down and look at their individual performance. But as we know, individual performance can go up or down based on particular patients, based on particular times. And so by looking at a broader group where the group was aligned in delivering care, they found that was the best way to help reduce readmissions and, in their case, also achieve shared risk goals. A recent presentation by the corporate director of enterprise analytics at Orlando Health in Orlando, Florida, it's a multi-hospital chain in the Orlando area, took a hard look at what they needed for dashboards. And they said first the dashboard had to include 3 areas. Executive summary, a high level that allowed the high level people in their health delivery organization to see broad trends for all of their patient populations. Secondly, they needed to be able to drill down by different cuts, by hospitals, by service lines, by nurse stations, by physicians, ultimately down to individual patient detail. And third, they were big believers in some sort of risk scoring. In their case, they used the LACE model so that they could look at risk and do stratified reporting so they understand which patients to focus at. And we agree with that and are big believers that if you can identify the patients that need the most focus, you can marshal your limited resources to those patients. Let automated reminders and things work with the patients who are at your lowest risk, and take your nurses and other care coordinators and transitions of care managers and case managers and have them focus at the risky patients. When Orlando Health looked at those dashboard areas, they said, what data do I need? And they put the sort of list you see together here. Just a patient list, right? Length of stay, acuity, DRG codes, payer information, and so forth and so on. And they were able to lay out the information they required. Examples of that can show up all over the place. So here's an example of a summary level report that put together and showed trends across patients over 90 days and percent of patients with different readmission diagnoses, percent of patients that were readmitted, so they could start seeing trends. Hey, here were the diagnoses, and here were which of those patients were readmitted and why. And I could start seeing where my problems are. I know this is an eye chart, but you can see the bar chart is highest here for pneumonia under readmit diagnosis, and readmit reasons, number of patients were highest in respiratory. No surprise. So what are we going to do about pneumonia? Why are patients coming back? What should we do to try and understand? Are they healing as they go? And you can see other indices and so forth on this summary report, as well as trend lines and trend reports. That's the high level executive summary that Orlando Health just talked about. At the details level, you can go and take a look by patient. This is an actual report from a client we're working with, and so we've redacted the patient's name, follow up the things that would make any of this PHI, so we can show it to you. But it shows patient by patient, date of appointment, date of discharge, the status. This report's looking at post-discharge appointment adherence and allows the care team inside the hospital to be able to look and track and say, how are my patients doing relative to post-discharge appointment? Are these patients getting there? Do we know they're going to get there? If not, what can we do about it? Should I have someone phone them? Should I notify the PCP? Should I notify other caretakers? So you can imagine This lets me look at the high-level trends, and this lets my care team, my case managers, care coordinators, whatever title you're giving these people, to day in and day out track what's going on with the patient. And Orlando Health said you need both of those in your dashboard. So in summary, we've taken a look at reducing readmissions using an integrated approach of people, process, and technology, recognizing the three areas that the Joint Commission identified as causes for poor transitions of care. And we recommend 4 major action steps for you. The first of those is understand your goals. Analyze your data on readmissions and transitions of care to define target improvements where the targets can be patient population, diagnosis, services. The data will tell you where you need to go. The second one is to do methodical business process review and engineering. What are your current processes? What new ones do you need, and how will they help impact the goals, and how will they address the various transitions of care causal factors? The third is you need to put together a multi-organization and multi-discipline team. And we see this all the time. We have a committee, people say. Great, what is the committee doing? They're talking. Okay, but is that solving anything? Well, we're talking a lot. We meet every week. But you know what your goals are. You know where you're trying to make change, and you have a thoughtful plan and set of processes and approach to making that change. So your committee goes from talk to action. And lastly, technology can be great at helping all of this. And the key is to identify and implement technology well and identify it so that it enables achieving the improvements that you've targeted.